Welcome everybody. It's Thursday, August 11th, beautiful sunny day. Gary and I are back. It's been a wee while. Gary was off at a CME course trying to learn. We've got a big show today, lots of information. Remember back when every week we were filming and doing a lot of COVID, there was so much information. Well, that's monkeypox now. The information is really rolling out quickly. We're on that escalation phase, so we're going to spend a lot of time on monkeypox today. But before we get there, our first slide, let's start with the epidemiology. And this is where we're at. You can see the COVID cases as documented at the lab are falling nicely. Not entirely sure how this correlates with the real cases because this is just lab cases, and as you know, most people are testing at home and not calling those cases in. But all looks very encouraging. But Gary, what's happening in the hospital?
So right now, by Sonoma County, there are about 37 cases in the hospital in our county. There are 3 in the ICU. Right before I left, a week or so ago, I lost a patient in the ICU to COVID. So we're still seeing COVID deaths, but they're much more sporadic.
Okay.
I think the outpatient activity is, still at a pretty steady state, even though I think that our testing is eventually going to be dropping even lower than it has right now. But we're still seeing sporadic COVID deaths and sporadic COVID cases in the hospital.
Vaccinated or unvaccinated?
The person I lost was unvaccinated.
Yeah. And the trend in the hospital, so sporadic, but is it just stable or is it going up, down?
It's actually going down.
Yeah.
It's going down.
Okay.
And still about 2/3 to 3/4 of the patients in the hospital are incidentally diagnosed with COVID, but a few, and very few, are coming in with symptomatic disease.
Okay.
So it's still good to vaccinate your patients and recommend that.
Okay. So now we have some information about the variants. Huh?
Yeah, so I just want to let everyone know, where are we right now? I mean, you see the humps, the alpha wave, the delta wave, the Omicron wave. Right now, what we're seeing is a subvariant of the Omicron. I'm going to show you how we track that information. So this next slide is from the CDC, and as you can see on the left is a map of the United States. And we're in section 9. So 9 is a western section that includes Nevada as well as California. Now to the right of that, I'm going to show you this bar graphs. Each of these graphs represents a week, and the bar graph to the far right represents the variants that are circulating in this region 9. And as you can see, as of August 8th, almost all of it is BA5, and that's that teal, the dark teal is BA5. If you look to the left of this, just in May, what was really circulating was BA2 and a subvariant of BA2. And so you see over time, as a new contagious subvariant comes up, it takes over and it becomes predominating. So BA4 tried to come up, it didn't not much happen, and then BA5 came up, and it's really 90% or more. So 90% or more, 99% is BA4 and BA5, and more than 90% is just BA5 alone. So that's important. So let's go to the next slide. The next slide's important because I love this slide. This is a slide that shows the phylogenetic tree. And as you can see, in the phylogenetic tree, the ancestral strain has a circle around it, WA1. And if you look to the right of that, you can see that all the variants, alpha variant, delta variant, gamma variant, they all kind of went out from the ancestral variant. It's not like alpha then became delta, then became gamma. They actually all evolved independent of one another. And then the Omicron one is to the far right. And in the Omicron strain, you can see BA2, BA3, BA4, BA5. The good news is, and I'll put this at the bottom of the slide, the good news is that a bivalent vaccine is coming out. It's going to be very likely approved under EUA in late September. And the bivalent COVID vaccine is going to be 2 parts of the virus. One strain is going to be an ancestral strain, and the other strain is going to be a BA4, BA5 strain. So we should be ready for that in the late part of September. So a lot of vaccine stuff's happening in September. Flu vaccine is going to be coming out, seasonal flu vaccine. Dan Early is working on that. Sarah Prysock and I are working on the monkeypox vaccine. We're going to talk about that in just a minute. And then this bivalent COVID vaccine is going to come out. So many of us are going to be getting a 5th dose. And so that's going to be the next booster. So as we head into the flu season, we won't be unprepared.
So just keep your fingers crossed there's no BA6 between now and then.
That's right. It's so far on the horizon.
Yeah.
Usually we have a month or 2 to see what's out there.
Yeah.
There's nothing on the horizon right now, which is really kind of unusual. And that might be part of the endemicity of COVID, of this COVID pandemic. But we don't see another variant out there yet. So I think that's really good news for the winter.
Good. So let's move on to the new topic, which is becoming the topic with our video presentation. So monkeypox.
Yeah, so a lot's happened since we last met with monkeypox virus. And I put a couple of historic things in this first slide. July 23rd, the WHO, World Health Organization, declared monkeypox as a public health emergency of international concern. What's interesting about that is it was a very split vote. Not everyone on the WHO wanted to do that. Not that it wasn't extraordinarily an event, but it wasn't that virulent. And so they didn't want to panic the public on the tail end of this COVID-19 pandemic. And then August 1st, Governor Newsom came out and declared a state of emergency. So New York was the first to do that, and then California and Illinois were quickly behind that, declared states of emergencies. And then August 4th, the White House, with the Human Health Secretary Javier Becerra, declared a federal public health emergency for monkeypox as well. So those kind of happened in sequence. What's interesting is the World Health Organization director said, this is mainly so far a disease of gay and bisexual men who have sex with men, and so please limit your contacts. But the CDC didn't say that. The CDC didn't come out and say that this is predominantly a disease so far in the gay, bisexual, and men who have sex with men population. And so what happened is that a lot of people became afraid. A lot of people in schools, a lot of people in sports, a lot of elderly people in nursing homes. And so I think the CDC was trying to be politically correct so they wouldn't stigmatize a population. But in doing so, I think there was a little bit of a backdrop to that. So worldwide, things stand right now at 31,000 cases worldwide. There have been 7 deaths outside of Africa from monkeypox. And they've been, a lot have been healthy people. One patient in Brazil was 41 with lymphoma, but 2 cases in India, 2 in Spain, have been in 20 and 30-year-old healthy people, and mainly they're dying of encephalitis. So encephalitis seems to be when you get this viremia from the virus, how it can be dangerous. In the US, we've had no deaths, but we're approaching 10,000 cases in the United States. California's at 1,300 cases plus, and currently in Sonoma County, we're at 17 cases, and no one hospitalized in Sonoma County.
And Gary, this is meant to say there's been only 2 pediatric cases in the United States?
No, so 5. So 5 pediatric cases in the US, 2 in California, 2 in Illinois, and 1 in DC.
So generally excludes that population.
Right, and the pediatric population so far has been from very close household contacts.
Okay.
So the next slide is interesting. I think this is telltaling, and you can see that these are the case numbers in the top 6 countries. The United States is leading the bandwagon there. So right now we have the highest case numbers in the world, followed by Spain. Then the United Kingdom and Germany might be flattening out a little bit, and then France and Brazil bringing up the end there. So the US is number 1, and I don't think we're slowing down. I think our case numbers are really going to be quite high. The next thing I'd like to present to you is, and this is very important for epidemiology, this is a paper that was produced in the New England Journal of Medicine. It came out on July 27th. And this paper was the first 528 cases in this consortium of clinics across 16 countries. And I show the map, but these are the countries that were represented here. 84% of these cases were in Europe, and then another smaller percent were in the US. So obviously this kind of took off at 2 rave parties in Europe first, and then spread throughout the world. And this is what's important. Of those 528 cases, and I'll break this down for you on the next slide, 98% were in gay, bisexual, and men who have sex with men. Now, there were 2% or 9 patients that identified as heterosexual or straight, and there were no women infected in these first 528 cases. 75% of the patients were white, the mean age was 38, 41% were HIV positive, and 57% of these were already on PrEP. So PrEP meaning pre-exposure prophylaxis for HIV prevention. And so this is a fairly sexually active group. 9% of these patients had previously had smallpox vaccination as a child. So again, smallpox vaccination in the distant past doesn't really protect you for monkeypox because your immunity probably wanes. 95% of transmission occurred through sexual activity. So I'm going to go on the record and say monkeypox is a new STD, and that clearly was demonstrated in this study. In fact, 29% of these patients had another STD at the same time. 3 of them were acute HIV. but syphilis, gonorrhea, herpes. Now, we also know that monkeypox DNA is in semen, and in a recent study just last week, there actually has been infection in vitro into Vero cells. So we're able to use semen to infect other cells, but we really think it's contact. It's contact with a lesion, just like syphilis, just like herpes simplex. 95% of patients presented with a rash. Incubation period is a week. 68% of patients only had an anogenital lesion. 23% only had an oropharyngeal lesion. So this is anal intercourse and this is oral sex. That's leading to, now there were also some other lesions along the trunk, on the arms, in the hands, but the vast majority of lesions in patients were in the anogenital area or in the oral pharynx or around the lips. Some patients had a fever, some patients had lethargy, but this is different from classic monkeypox. Classic monkeypox in Africa has a very prominent prodrome of a flu-like illness, then leads to widespread lesions throughout the body, and that probably represents a viremia, kind of like chickenpox. This is different. This seems to be contact spread with very few and not very prominent prodromal symptoms at all. So that's the cohort. And I want to just say something about that for just a minute, because I think it's important that the CDC try not to stigmatize anyone. And I think it's important that they're going from the HIV historical epidemic we've had in the last 30 years. And what we know about good studies on STDs and good studies on HIV transmission, what we know about in the US and in the UK from these studies are there is a significant proportion of our population that is gay, bisexual, or identifies men who have sex with men, but this entire population is not at high risk. This entire population is not having high-risk sex. And there's a cohort of the population in the straight community that is having high-risk sex. But what we do know about HIV transmission and in the increase in STDs recently is that a small percentage of the population of gay, bisexual, and men who have sex with men are at tremendous risk. And we know that because that's how we've been doing PrEP. 99% of the PrEP that I do in my clinic is gay and bisexual or men who have sex with men. And so we're following that with monkeypox. So it's not all gay men. It's a very small but significant subset of the gay community with men who have sex with men having higher risk sex.
So from the clinician's viewpoint who are fielding questions from the entire population, the data is pretty supportive, saying we have identified the at-risk cohort.
That's correct. Right. Now, in time, there could be a spillover effect,
sure, right at the moment.
But right now, and since that study's been done, to date, as of today, 99% of cases are in MSM community.
So it still holds.
That still holds today. Now, in the future, could it end up in kids? Could it end up in a nursing home?
Sure.
Could it end up in colleges? You know, as an STD, it probably will eventually. Yeah. We haven't seen that spillover effect yet.
Okay, so for the current state of knowledge, such that when our clinicians are fielding phone calls from the variety population of mature individuals, infants, pediatrics, they can safely say you're not in a high-risk group.
That's correct.
Okay.
That's a really important point because I have patients who are elderly, patients from Oakmont, who are not gay and not high risk. Everyone's kind of freaking out because the information's been very, very limited from the CDC.
Okay.
I put this next slide in here just to show the U.S. cases, and the New England Journal article was published on the 21st of July, but there's been a tremendous number of cases, and it's the same community there. The next slide is a map of the U.S. This kind of shows where the hot spots, and of the top 10, New York is number 1 with 2,100 cases, and California is number 2. Texas has made the top 5, and we're going to see continued spread. So we have not peaked yet, and we've not even been close, I think, to the peak of this so far. Now then the next slide, I'll show you kind of what are the issues at hand right now. The monkeypox issues right now are testing, but we're good with that. It's in Epic, testing is available, our lab will send it to Quest and LabCorp. We've got that down. What about vaccine? The vaccine Jynneos has just today been approved by the Human Health Services in intradermal fashion, which means that now we can take the standard dose and use 20% of it, and now a single dose can be 5 doses. And that's going to be very important. It's only indicated for tier 1 and tier 2 cases, which is post-exposure prophylaxis. If you've been exposed to a case, confirmed case, highly suspected case, then you're going to be in that tier 1 group that vaccine is going to be useful for you. This is not PrEP yet. We don't have enough vaccine to say pre-exposure prophylaxis for someone who's going into a high-risk situation is an indication for vaccine. We only have 20 doses in our hospital, so 20 doses has to be distributed to all the patients we need to vaccinate in the community so far. We've been in contact with Sonoma County Public Health, and all doses are coming through the health department. So we're trying to get more vaccine from the health department, and we're trying to coordinate a vaccine effort.
And that's the only source? All vaccines are coming through the public health?
At this point, all vaccine is coming through public health, and Sonoma County only has a trickle number of doses.
Because we hear about it being much more plentifully available in San Francisco. But
Right.
that may just be because they have a very sophisticated public health department.
Well, what happened is that the State Department said, here's how we're going to allocate doses, and rural areas didn't get as much.
Yeah.
So San Francisco and Los Angeles got a tremendous amount of vaccine. We didn't get as much. And we're going to do, and now that we have these 20 doses, that really is 100 doses now, because now we can break it up
Yeah.
into 20% doses, which is going to be really
But it's
important.
important to note, I think, for the press, because I think the press got this wrong. Sutter has not received any vaccine. They're all trying to receive it directly from public health.
That's correct.
Okay, all right,
Yeah,
thanks.
that's important. So I want to just shout out to Sarah Prysock, who's been great in helping trying to stand up a clinic, and Dan Early's been super supportive. By next week, we hope to start vaccinating. We will probably use my clinic as a vaccine site, and we're only going to do tier 1 patients.
Okay.
And so please, if you try and order the vaccine, you won't be able to, because at this point, I will be the only one ordering vaccine.
Okay, so more to come when you're at the time of opening that clinic
Right.
about how to refer people and so forth, but that'll be
Correct. Yeah, that'll be our next video. Now, what about treatment? Treatment is even murkier. Treatment is tecovirimat. Tecovirimat is an oral therapy for treatment, but it's not the Tamiflu of influenza, and it's not the Paxlovid of COVID. We're actually earmarking the few doses we have, 6 treatment doses. We're earmarking that for the hospitals for severe cases. Pregnant woman comes in with monkeypox, we don't want the fetus to get infected. Someone comes in with severe disease and or encephalitis. We're going to earmark her for that. This is not going to be outpatient disease. Now, San Francisco has a little bit more of tecovirimat, and they're using it much more liberally. But the CDC guidelines are use it for patients with severe disease or very likely to have severe disease. So tecovirimat will not be available at this time in the ambulatory setting.
Okay. One other issue, it's not directly in here, but I think it'd be good for our clinicians. We understand who the at-risk cohort is. Can you comment on transmission? Because that's out in the public too. Is it aerosolized? People have to be, they saw somebody on the bus, we thought
Right.
they might have monkeypox, or they exposed. What can you comment?
So there are 3 phases of transmission. The most common one is skin-to-skin contact,
Okay.
and it's intimate, repeated skin-to-skin contact. And so high-risk sex in an anonymous or hooking up fashion is going to be a risk for that. And we're seeing that. We saw a number of cases come up from Pride, from the Pride events. But that's intimate contact. The other place for intimate contact repeatedly would be in a household.
Yeah.
So if you're caring for a child or your spouse is sick, you're going to come into contact very closely with that person. Outside of that, it's not you bumped into someone at Safeway.
Aerosolized?
Yeah, it's not that you bumped into someone at Costco. Now the other mode is fomites. So what about clothing? We know that in someone's bedding or clothing, if crusted lesions fall into the clothing, those crusted lesions are infectious. And so in a household setting, like if you're sleeping in the same bed as someone, that could be a risk factor. But if you're on the BART and you bump into someone who happened to have monkeypox and they're wearing a jacket, bumping into someone with clothing is not going to be a risk.
Okay.
So it's not casual contact, it's not casual fomites. It's household settings and intimate. In the aerosolized thing, we thought that respiratory secretions might be a big thing here, but they're not. Because in Africa, where it's endemic, when you have that rapid and severe flu prodrome,
Okay.
there's a lot in the secretions. We're not seeing that prodrome.
Okay.
And so the respiratory secretion part of this is incredibly low.
Okay.
And I wouldn't say 0, but it's next to 0.
But it's a good clinical point. We don't have to worry about those. It's really contact, skin-to-skin contact.
And that's why it's probably like an STD.
Okay,
Yeah.
thank you.
Now, I want to just apologize to everyone. That is a lot of information we've just given you.
Yeah.
So, and again, happy to send on the slides if that helps everyone. The last one I have on monkeypox here is, I have 2 more slides. One is, these are exactly from CDPH, California Department of Public Health. These are the tier 1, tier 2 categories. Post-exposure prophylactic with known contact cases, that's tier 1. Post-exposure prophylaxis or PEP++ with certain high risk factors is tier 2. And also, the only prep recommended by the state or the CDC is occupational risk. So people working in the lab, for example, or us clinicians who are collecting swabs, that's a tier 2 category as well. And employee health is working on that right now. We hope to have more information for them in the future. Now, if you're watching your email, you probably saw this. This is the next slide. That a center sent out a number of dot phrases on monkeypox, and they all start with MPX. So if you want to send a dot phrase about illness, about vaccine, about messages, certainly you can take a look at these and see if they kind of work for your processes with patient communication.
All right, that is a lot of information, folks. And next time we talk, it'll probably be slightly different. But I think there's some really good take-home points that will help you deal with the general public who is understandably alarmed because the way it's been presented has been just kind of a widespread, community illness, which we now know is not the case. So we know the cohort that's at risk. We know the mode of transmission. So hopefully that will help you in dealing with the public. And we have more to come. Treatment's not an option right now, really, for us in the ambulatory world. But vaccination site will be coming up soon. It'll be very clear who qualifies for vaccination.
Correct.
Okay.
Yeah.
Thanks for listening. Hope that was helpful. Have a good day.